All right, it's live in 2 seconds. All right, it's live.
Okay, welcome back everyone, and welcome to another session of Pre-Dental Universe. I'm Tiffany, one of the pre-dental students monitoring today's session, along with Sherry. We have an exciting presentation today, and before we begin, I would just like to thank the doctor for sharing your experience and some of your professional insight with us. And on that note, feel free to take it away.
Well, thank you so much for your time, Tiffany and Sherry, and Happy New Year to everyone, of course. So I'm Dr. Hasan. I'm a board certified orthodontist. I do practice in the DC, Maryland, and Virginia area for about the last 5 years since I graduated my residency. To give you an idea where I'm originally from, originally from Iraq, born and raised there. I finished my first round of dental school in 2007 where I got my bachelor's degree, and then I came to the States in 2008. Then I pursued, my dental education. I got my DDS from University of Colorado in Denver, graduated in 2011. And after that, I got my residency at VCU, which is in Richmond, Virginia. And that's been, where I got pretty much my periodontal education. As far as today, for me, I'm going to just kind of talk to you guys about what my passion is and how I got into the world of periodontics. It is a 3-year residency program. Those who hopefully have a chance to get into it. It's very multidisciplinary. If dentistry is going to be your passion for the long term, we do have that opportunity to work with the orthodontic department, from oral surgeons as well, the prosthodontics, and just your general dentist as well. So it's a wonderful collaboration. Perio, we think about as we're the foundation of the teeth, which means we deal with gums and bone, and we want to make sure that everything is stable and healthy, so people can save their teeth for the long term possible, as long as possible. I'm also a part-time faculty. I teach at the VCU Dental School. So I go there, drive from DC once a month, and I'm usually with the residents for the full day, kind of just teaching them the ins and out of periodontal surgery. So it is fun for me. It's exciting, and it's also something to give back to my residency as well. I've been teaching for about 4 years, and hopefully for many years to come. So hopefully, if anyone's in the DC area, please feel free to reach out to me at any time, and love to meet with you guys and kind of encourage you towards the dental path. Today, again, just kind of be talking about what I do on my most day-to-day basis, which is about gum grafting. Most of us here do have at least some form of what we call as gum recession. And I'm going to go talk kind of a little bit about that and what we do on how we can improve it for our patients, whether you're 8 years old or you're 65, 7 years old. So what you're going to see here today is really different cases, surgical approaches as well. If it's too much, do let me know, and I can just kind of skim through some of them pretty quickly. But you'll definitely have an opportunity to see the before and after of those cases for you, and how much we've improved it for our patients and for the long term. So today, again, we're talking about definitions, history, classifications, our indications for those procedures, when and when not to do them, and also the techniques, that's advantages, disadvantages, and the limitations for it. So again, going back to our definitions, so soft tissue plastic or mucogingival surgery, basically these are procedures that are designed to correct any defects in the morphology, the position, or the amount of gum, the gingiva that surrounds our teeth and also our dental implants. Recession is the displacement of our gum margin or gingival tissue, which is down away from our CEJ. That's something, a term you're going to learn a lot in dental school once you get into it. If you're already our dental assistants, pretty much know what the CEJ is. But again, that's something you're going to pick up more in dentistry as you move forward. So again, think about it this way, what recession is. Thing is, this is your tooth. At this point, if you're seeing, I'm not sure if you can see my hand or not, but if you can see my hand very much, think about this. This is your tooth, and you have a gum margin right here, and very much your gum is just displaced apically. So now some of your root is showing, and we did get to experience sometimes gum sensitivity or root sensitivity, I apologize, and therefore our goal is to see what we can do to fix that and make it look as natural as possible. So, what are the main things that can cause these defects or those gum recession? There are predisposing factors, which means that some folks just have minimal attached gum. And that could be a lot of it is genetics. We see that all the time. It does have a major role in the people developing future gum recession. Some patients have what's called a frenum pull, which is like a small muscle that tends to pull the gum away, and that can cause future defects in the amount of gum that's present. Also, the position of the tooth. Sometimes you'll see the teeth are like too far out or too far in or rotated. Those can all be factors in developing future gum recession or defects as well. Other factors are precipitating factors, which means that sometimes it could be just folks, they brush the tooth, but they forget the gum. And over time, what you'll see is a lot of food building up around the gum line, and that gets really inflamed as people are not brushing it, and therefore it can predispose it or precipitate it to a future gum disease, gum inflammation, and future gum recession. And sometimes it's actually could be dentistry related. Sometimes we'll see a lot of our doctors, what they'll do is they'll put a filling or they'll put a crown, and it's just too close to the gum. And the way our body reacts to it is that it's either going to recede away because you're violating that natural habitat of the gum, or sometimes the gums will just get super inflamed, that it will start bleeding excessively. So we need to always respect the natural architecture of the gum and the bone, and that we're not impinging on it so we don't cause any future issues down the line for it. One of the things that I do see more common than anything else is orthodontic therapy. I would say about 90% of gum recession cases that I do get to treat is a history of orthodontics. I would say at least 90%. I do see very few of those orthodontic cases where the orthodontist was diligent enough to send us those cases before they start the braces just to improve the quality of the tissue. But most of the time, it's usually with patients who've had braces in their teens. Fast forward 5 to 10 years later, and now we're seeing very thin gums. The roots are almost kind of bulging out. And you can just put your finger, and if you feel the roots, inside your tooth, that means you have very thin tissue and that you might be predisposed to future gum recession. So we do see that a lot, and our goal is to always educate our referrals as much as possible, and also our patients, so that way we can kind of prevent that from happening later on in time. Anatomical factors, these are called just pretty much abnormal tooth positions in the arch itself, in the jawbone itself. Sometimes the way the tooth erupts into the jaw, that can also lead to recession defects. And sometimes even the shape of the tooth also has those effects as well. And last but not least is your pathological factors. That means just purely gum disease. And that means you've lost bone from advanced gum disease over the years, where there's been a lot of neglect from the patient at that point in time. And then you'll all of a sudden see a significant amount of bone loss, bone resorption from that disease, and the gums just tend to follow it. And then you'll see a lot of recession happening over time. So these are pretty much your main factors that can lead to gum recession. And hopefully, as you go into that dental profession in the future, you'll be able to see it, and help diagnose it and know when to treat it and when to refer it out to your specialist, to your periodontist. So going back to some history, because our topic is about the evolution of soft tissue grafting. Again, history about soft tissue grafting goes back way almost in the 1950s. The first procedures were developed. Most of the research was done anywhere between the 70s, 80s, 90s. I think that was one of the early research that was done about it, and the most extensive amount of it. So the big question is, well, how much gum do we really need to maintain health, around our teeth? Some studies say that you need at least 2 millimeters of a good amount of gum, and that should be enough to prevent any kind of inflammation. Some of them say, actually, you need 0 gum. As long as you maintain good oral hygiene and good home care, that can be sufficient. The way I was trained, I do believe that we need at least anywhere between, 4 to 5, in my opinion. Sometimes, say minimum of 2 is definitely necessary, but the more the better, because our gum acts like our skin. It's our first kind of physical barrier that prevents any germs, bacteria from getting underneath it and down to the tooth, into the bone. And that way it helps prevent any future bone loss. So that's usually kind of give you an idea about the history, when, as far as how much gum do we need. So again, going back, again, from the 1950s to the 70s, a lot of techniques were developed, and the goal is just to increase the amount of gum that we were looking for. How much gum I can have to make it better and stronger. Not necessarily the thickness or covering the root, but just increasing the gum in a width proportion. So a lot of techniques were developed. The famous of them all was called the lateral pedicle flap, and I'll get into that a little bit with a couple of cases to show you. What's called the free soft tissue graft or the free gingival graft. If some of you remember, or some of you have had it, they take a small piece of gum from the roof of the mouth and they put it right here between your two front teeth. That's the most common ones, and the lower jaw. And I'm sure you remember all the burning sensation in the roof of the mouth as a result of it. There's a double papilla graft, and your two-step procedure where you start one procedure, then come back 6 to 8 weeks later, and you pull up the gum again. So we'll get a chance to kind of go over a little bit of everything for you today, just to see the before and after. And honestly, till today, we still use those techniques, even though they've been developed close over 70 years ago at this point in time. From the 1980s to present till now, a lot of different techniques were developed, and they are more aesthetically driven, number one, and also the goal for it was to improve the root coverage. When you improve the root coverage, a few things can happen. Number one, patients don't get a lot of sensitivity anymore. If they're planning for future veneers or crowns and they have really a lot of gum roots showing, the new techniques have been developed to really help aid your restorative dentist, which is hopefully going to be many of you guys here, to really kind of get everything back to normal again. So there's what's something called the envelope pouch, or the new technique, which is developed by Radsky in 1985. The subepithelial connective tissue graft, that was developed in 1985 by Langer. That's the most common one that we do use in today. The semi-lunar coronally position flap, not very much that's applied, but it does have its indications. The double papilla flap, again, with connective tissue by Harris, we do that a lot as well, but it has decreased over the recent years just because it's very technique sensitive. The one that I think for me personally, what I do the most is the tunnel technique, which is a modified envelope, and the one after, which is the coronally advanced flap. Those ones are pretty much our bread and butter. We do it, I'd like to say, and maybe 85 to 90% of our gum graft procedures, they're very minimally invasive to a certain level, and the results are unbelievable and very rewarding for both the surgeon and the patient as well. Other techniques that have been developed was actually adding more of a biologics. So different biologics have been developed over the last pretty much 30 years to 40 years. Some of them are called Emdogain, which is made of a porcine tooth bud. It's enamel matrix derivative, which it's been broken down with tooth buds, and they use that the protein matrix of it, and that helps in regeneration of the gum and the bone. There's something called GEM21, which is a platelet-derived growth factor, BMP2, and PRF, which is platelet-rich fibrin, and bone morphogenic proteins. So these are all, that's been science that was kind of developed over the last 34 years on how to do things more naturally in a biological way. Another thing is allografts, which is pretty much what's called, you're taking skin from a human, from donor tissue, human skin. Those have been phenomenal. We do use those a lot. They were actually first used for patients who had breast cancer, female patients who had breast cancer, where you would take actually donor skin, apply, and help the skin to regenerate. Many years later, they tried to use it. It's like, oh, we can actually use it inside the mouth for gum grafting procedures. And they have been very predictable for almost 20 years now, actually. When it comes to comparison, and I'll share it with you at the very end, the difference one versus using your own tissue, which we harvest from the roof of the mouth, versus donor skin. Our own tissue is always going to be considered the gold standard, and it does have much better long-term efficacy. And one other product is xenograft, which means that comes from an animal. So the ones that are really famous are the ones that come from pig skin, and those have been shown one of the most amazing results in comparison to our own tissue. However, it's still not fully approved yet as far as in the US from an FDA perspective, so especially with the Micograft. The other ones, the FibroGuide and the Mucoderm, again, those ones have been approved in the US except the Mucograft, except the Mucograft at this point in time. Again, and over the years, again, there's something also called the combination techniques, which means that you can just use something from the old technology and the new technology and just apply them together. And you get the best of both worlds, which means you get to apply all the techniques that you used in the past and apply it to what you learned today. So that does help kind of get you the best of both worlds again and achieve much better long-term results. So sometimes you can add the lateral pedicle flap with a connective tissue graft and put those together. You can do what's called a guided tissue regeneration, which means you're adding specific products and materials from bone and membrane and biologics to aid in some bone regeneration process. So those are all new techniques that have been really cool and helped us as periodontists over the years really advance the technology and really make periodontal procedures more fun and also more predictable, in other words. And again, other techniques is just your simple coronally advanced flap, which means that we're just pulling down the gum again that was recessed and adding biologics to it. And that's, again, one of the things that we do very, very commonly in today's procedures. So moving forward, the way we really talk about gum grafting is we always have a classification like anything else we do in dentistry. So for example, if you're going to know about fillings, there's a class 1, class 2, class 3, class 4, type of filling material, fillings, or, cavities. In a soft tissue world or soft tissue graft, there is one famous one. It's called the Miller classification. And there's another one called the Cairo classification. I'm going to be just discussing the Miller classification because it's very easy, straightforward to understand. The Cairo is a little bit more, I would say, has its very different own unique classification that it does take some time to get used to. So I don't want to get too nerdy with you guys about it, but I just want to make you hopefully understand just the basics of the classification. So again, developed in 1985, and it has, again, 4 different classifications, 1, 2, 3, and 4. Class 1, Miller classification, basically, you have recession. It doesn't extend to the mucogingival junction, which is the line between what's called the attached gum and the loose tissue. That junction is called the mucogingival junction. So basically, you have recession does not go beyond there. With those ones, what's key about them is you don't see any signs of bone loss between the teeth. One of the key things that gives us predictability in gum grafting procedures is how much bone do we have between the teeth. The higher the bone levels between the teeth, the better the coverage we can achieve for our patients. So the first thing we do check is we always look at x-rays and we always use our periodontal probe to see exactly where the bone is. Based on those factors, we can gives us a rough idea or estimation how much coverage we should be expecting. So in those cases, when you have minimal recession that doesn't go to that junction and you have no bone loss between the 2 teeth, our coverage is pretty much 100% is possible, which means it's predictable. So we can achieve it, very often. Class 2 is very similar to class 1, except in one factor is that you do have recession, but this one extends all the way down to the mucogingival junction. You can see that very distinct line. You got the pink and you get below is that kind of reddish, and that is your mucosa. That's the extension that goes to your lip, it goes to your cheek. So if that recession goes to that level, then you're about a class 2 Miller. Class 2 Miller also, there's no bone loss. So with those ones, we can also achieve root coverage simply because we do have high bony peaks. The reason bony peaks again are important is because when you pull up the gum, you're kind of slinging it, and the only way to keep it nice and high and taut is if you have your adjacent bone is really high. So that way the suture wraps around it and keeps it taut up. So that way it gives you an idea on how gum recession works, or at least root coverage. Class 3 Miller is, you'll see a little bit of signs of bone loss, and the way easily for us to see that is by sometimes you'll see what's called a black triangle. So you can see that small triangle between the teeth that's black in color. That means it's a through and through. If it's in the early stages, that means you have a little bit of bone loss. And you can see a small amount of that black triangle. So that's a Miller class 3. That means there are signs of some form of bone loss in between them. So is root coverage 100% predictable? No, not really. There are some techniques out there that are being developed to kind of challenge that. So again, it's just in the process at this point. Some of them have been amazing in developing, and as far as covering those, they've had some incredible results. But again, it's still one of those ones where it's still kind of the iffy situation where it's not always predictable, but it can be achieved every now and then. Class 4 Miller is the one where those are patients that have a history of gum disease, very severe, very advanced, and they've lost the bone, and the gum followed it as well. Pretty much for those ones, we don't expect to see any coverage at all. If the patients do need it, it's more for thickening the tissue and make it better, stronger, and more resistant to any future progression. So give you an idea, this is what a class 4 Miller. Again, you'll see huge triangles, a lot of bone loss. So I'll give you an example. This is at least about a 25% bone loss around your natural tooth. Again, so that's where the bone level is. In comparison, if you look at to where the patient's level is, it's around that line, around that margin. So when you have bone that's that low versus it's supposed to be much higher, you're not going to expect a lot of root coverage. What is the purpose of it? It's mostly for thickening the tissue. If patients, let's say anytime they brush it or they have difficulty brushing it because the gums are too thin and too sensitive, then we always like to improve the quality of the tissue so that way they can do a better job maintaining it for long term. And again, it does help sometimes kind of stop that future progression for the patient. So do we do these procedures for our Miller class 4? No, not really, not much, but they do show up every now and then. Now, in 2018, finally, there came a slight update to the Miller classification, which was kind of really cool and interesting for us because, they always looked at, well, how much does the patient have recession? Where's the bone? One thing they never looked at was that beautiful pink triangle between the teeth, and we called the papilla. So for us as periodontists, we are incredibly anal and OCD about papillas because we want to keep them intact as best as we can. We hate seeing our patients lose our papilla. No one likes a black triangle. So that's something we always kind of work very diligently to maintain and preserve, even though you're talking about 0.5 millimeter or 1 millimeter, but we do really kind of consider it very holy for us, at least in our opinion. So the papilliform classification came out in 2018. Type A pretty much is it's described as no bone loss, but the papilla is more than 3 millimeters wide at the base. Those ones are great for us. Why is that? Because that means that there's a thick amount of tissue underneath that beautiful pink triangle. And that means it's good blood supply for our future gum graft. So it does help a lot having that for us to achieve for predictability perspective is the amount of blood supply. Type B is, there's also no bone loss, but the papilla is really narrow, which means it's less than 3 millimeters wide. So complete root coverage predictability is compromised. So which means even if you have a Miller class 1 or a Miller class 2 where there's no bone loss and 100% coverage is possible, but when you have a type B with it, if you add that new classification to it, you'll kind of see, it does make sense now. Why am I not getting any coverage? And we used to see that all the time in the past, but there was just no way to properly classify it until 2018. And that's helped us a lot because now we can kind of, when we communicate with our patients, we can give them a general idea of what is expected from us to achieve for them. Lastly is the type C, where you do have bone loss, as we saw like when you're Miller class 3 or Miller class 4, or sometimes the tooth is just extruded, which means that it's come out of the bony socket. And that is very, very common to see that patients can develop over the years, especially if their bite is not perfect and it's not correct, or they have some history of gum disease. The papilla is less than 3 millimeters wide at the base, at the level of your adjacent CEJ. Complete root coverage, which is CRC, it's not expected, but it can be in some cases. Again, very rare, but it can sometimes be there. I'm not going to go through the chiral classification yet because it's pretty much way more advanced, and I don't want to bore you with many different classifications. But I just thought that the Miller, which is the most common one that we do still use in today's day and age, and the subtypes of it are the ones that I think every dentist, every periodontist pretty much should know, moving forward. So when do we do gum grafting? What are the indications for it? Sensitivity, that's one of the main factors that patients come in, hey doc, I'm brushing my tooth, but every time I drink water or every time, cold or hot, sometimes I just feel a zing that's coming there and it's really sensitive. What can I do for it? So that's one of the things. It could be an aesthetic dilemma, just like when they smile, you'll see a lot of their roots show. It's like, and it's very unpleasant to look at. And sometimes for sites that are just continuously progressing. Now, do we treat every gum recession that we see? And the simple answer is no, not really. If it's very minimal and there's no sensitivity, which means I have a 1 millimeter of gum recession, and there's nothing there for us to worry about, even 2 millimeters, I would sometimes just keep an eye on it because, at least for my personal experience, the ones with a minimal recession, if you try and treat it, it can bite you in the butt later on, in other words. And so it's always good to monitor them until they progress a little bit more or until it becomes really symptomatic, and then we can treat it as such. So what's interesting is there's a study by Serino in 1994, and he found that areas that have 3 millimeters of gum recession, they tend to progress 67% of the time, which means there's 67% that actually can get worse. Those who have 4 millimeters of gum recession, they can progress 98% of the time. So we don't like to see our patients go beyond 3. Once we see that number, we do strongly advocate, please treat it because it can get worse. And if it does get worse, that means that we have to sometimes do not only 1, but 2 procedures to fix it for them. So we do always, kind of educate our patients and even our referrals, because these studies, they don't know about it. So it's our job as periodontists to really tell them what is the chance of it progressing over the years. Another indication is sometimes the patients just can't clean properly, and that's really true. A lot of our folks, basically they try to clean it, but it hurts. Every time I put a toothbrush on my gum, it bleeds, it hurts, and when you look at it, you'll see a lot of gum inflammation, a lot of plaque buildup. And that tends to really make it super inflamed, and anything touches it is just so painful. So what we help them is we help them with the cleaning aspect. We educate them. Sometimes we'll do a cleaning at our office to get things healthier for them, and then we can maintain over time, and then slowly do a gum graft procedure for them. Another indication is pre-orthotherapy before braces. This is really common for our patients from 8 to 12 years old, and I'll show you some cases of my patients who you'll see there's some mixed dentition in their mouth, and they're getting braces, whether it's for expansion purposes, and they just need that gum in certain specific sites, so that way the orthodontist is a lot more comfortable, placing those teeth in the right position without causing too much compromise on the future teeth and the gums. And if you have any planned future crowns or fillings, for example, if you don't have a lot of gum to start with and you start doing those cases, there's a good chance that it will progress. And now you have a lot more problems to deal with later on in time. So these are all things that we always take into consideration when a patient is referred to our practice and how we can address it, how we can treat it. From a surgical standpoint, what are the clinical considerations? Again, chief complaint, well, why is the patient here? Anatomical considerations as well, that looks at the vestibule, which is, pretty much if you pull your lip and pull your lip down, put your finger in, where your finger stops, that's called the vestibule. Frenum, again, that's a small muscle that pulls the gum away. The width of the carinized tissue, that's the attached gum I was talking about, that's called the carinized tissue. How much wide it is it narrow? Is it wide? And again, your interproximal tissue, that includes both bone and gum as well. And again, is there decay, carious lesions, or non-carious cervical lesions? These are all things we tend to look at. If you've heard the term non-carious cervical lesions, it's those people who brush really aggressively and they've worn down that beautiful CEJ line. That's a non-carious cervical lesion. So abrasion, sometimes erosion from a lot of drinking acidic drinks that can result, or sometimes acid reflux can result in acid erosion, and sometimes even abtraction, which is from biting habits, especially aggressive biting habits or occlusion point of view. Again, the position of the CEJ, that's another clinical consideration. Is it natural, or is it because of a filling that was placed there at one point in time? So we take that into consideration because then it gives us an idea, well, how much gum can I pull up if it's a natural, and how much gum can I pull up if it's an artificial one from a filling? And sometimes we adjust those early in time. And how many teeth are we doing? Is it one tooth? Is it two? Is it 10 teeth? And yes, we do a lot of cases where it's the entire upper jaw or entire lower jaw. They're more demanding. You have to think about what materials you're using, the surgical technique and approach. That all comes into consideration as well. So one of the very first techniques that was developed, it's called the lateral pedicle flap. It's really cool. Basically, you have gum recession and you're just sliding it from the neighboring tooth, which has a lot of gum, to the one that doesn't have any gum. It's usually isolated, which means it's great for one, maximum two teeth, not more. And basically, we just literally slide it over and call it a day. And we close it up, and you'll have some really nice results over the long run. So advantages, it's a single site surgery. It has its own blood supply because nothing's being, the base is still attached, so there's blood supply. Perfect, ideal color match. The disadvantages of it is that sometimes you can get recession on the adjacent tooth that you just took it from. So it's not something that we do on a daily basis, but it is an option. You have to be very careful and methodical when we decide to choose to perform this technique, to take everything into consideration at that point in time. Again, indications, naturally, if you have it's an isolated defect and you have a lot of donor sites from the adjacent tooth. So give an example. Again, this is a single tooth site. Again, a lot of recession as well. The tooth next to it has a lot of gum, as you can see. So we do what's called like a small step back incision, and then we just slightly rotate it over. And this is it at literally 2 weeks later. So you'll see some really nice coverage. And this is at 6 months later. So you go from here to here by simply literally just moving the tissue from the adjacent tooth to the one next to it. No other products was added. You didn't have to harvest from the roof of the mouth. It's just a simply transpositioning of the gum itself. Again, isolated defects, but you have to have a lot of gum on the adjacent side to make sure that these ones are predictable and they do work. All right, another case as well. This one's interesting because the tooth with the gum recession, you can see the root. It's actually slightly super erupted compared to the ones next to it. So, and if you see the papilla, it's really narrow. It's not super duper wide. So you can predict already, like you're not going to expect a lot of coverage. So this would be classified as a class 2 Miller because you have recession. It does go to the mucogingival junction, but it's the type B or the type C in those cases where you'll see some slight super eruption and very narrow interproximal papilla. So again, another lateral sliding pedicle, but this case, we combined it, which means that we took some gum from the roof of the mouth and we combined with a pedicle technique to achieve a result. So again, this is it. That's the small gum from the roof of the mouth that we harvested, and it's nicely sutured. Again, this is the day of the surgery, not the prettiest suture. I do have to confess, I've done a lot better. This was not the prettiest of them all. But again, 6 months later, now you have a beautiful thick band of gum. That's not going anywhere. That's going to stay for the rest of their life. The good thing is it's the lower teeth, so really no one can see that discrepancy in the color. But the key thing is you have very long, better quality of tissue, functional tissue that can stand, good brushing, eating as well without causing any future problems down the line. Again, and we got some coverage of that exposed root compared to the past. The reason we didn't get 100% is because that tooth is actually slightly super erupted if you look at the CEJs compared to the adjacent teeth. So there has been an issue with this tooth to start with. Ideally, sometimes you can do braces later on to literally intrude it, push it down to correct everything for the patient. That would be more an ideal long-term situation. Another technique is called the double papilla technique. I'll be honest with you, I've maybe done this case once in my life. It is the most technique sensitive cases, a surgical approach. I have a lot of colleagues who love using this because they were trained a lot to be doing this technique, and it works phenomenally in their hands. I've again done it once only. I have no intention to it again because there's just a lot of other ways that are much easier and more predictable. So again, it has its also own blood supply, ideal color match. Disadvantage again, scarring, which is insignificant in my opinion at the vertical incision line. As you can see, there's 2 vertical incisions. You need a second site, which means you can harvest from the roof of the mouth. Indications, again, another isolated defect, and you have to have a lot of gum from the adjacent teeth. So what does it look like surgically? So this is an isolated defect. Again, there's a lot of ways you can approach this, but this is a case where I thought it was a good idea to do a double papilla technique. So again, you basically make your small incisions vertical, and then you kind of close the ones in the middle as shown in the illustration below. And then you add a gum graft from the roof of the mouth and you stabilize it. And then you close everything back up. And then this is what it looks like about 4 weeks later. So again, major improvement from the first picture to the last picture, the quality of the tissue that you can see, and pretty much you covered all the roots at 100%. And now you have a thick tissue underneath it, which is that beautiful gum graft that we harvested. So these ones they definitely see a major improvement. Again, they're just a lot more technique sensitive compared to the other procedures that are out there. This one's called the free soft tissue graft. This is our bread and butter. If you haven't had this before your ortho braces, most of us have had at one point in time. Your orthodontist sent you to a periodontist when you were maybe 8, 9, 10, 12 years old, and you got a gum graft from the roof of the mouth, and they place it right here between the 2 front teeth or the 4 front teeth. If you hadn't had it, ask mom or dad. Most of them have had it at one point in time. So it's really, really common. These ones are really predictable. They're our bread and butter. A lot of them, it's not just about improving the quality of the tissue, but you get thickness, you get increased in the amount of attached gum, and a lot of the times we can actually even cover the roots. Even though this technique was not meant for root coverage, but in a lot of the cases we can actually achieve it, just depending on the blood supply that we can have for it. Now, it does look like a tire patch, as you can see, like really on that lightish pink. We rarely perform this in our upper teeth, but mostly in our lower teeth because from aesthetic purposes. So we are kind of limited as far as location wise. But just to give you an idea, I know that they do tend to look like this, and it's really normal. So advantages, again, you can definitely increase your keratinized tissue height, which you can see how much gum you have. That's your keratinized tissue. The disadvantages, it does require a second surgical site, which is the roof of the mouth. I do tell my patients it feels like a bad, crappy pizza burn for about a good 7 to 10 days. But there are a lot of ways we can do to make it more comfortable, for our patients. Adding a palatal stent that helps kind of add like a Band-Aid, that works a long way for them. So that is the second surgical site. Again, it needs a blood supply from the recipient. You have to have blood supply at the base because it's like an onlay. You're taking a piece of skin and you're slapping it on and you have to stabilize it. So it gets all the nourishment from the original recipient site. So the more bone you have, the more blood supply you have, the better the success of those cases are. Tissue color discrepancy, that's really, really normal. Indications for it, again, if you want to increase your keratinized tissue, that's pretty much the number one indication for it. And also you want to increase your vestibular depth, which is another thing. And you have that small frenum pole that tends to, pull the gum away. So it kind of helps do a 3-in-1, but just one simple procedure, and it makes it so predictable. So again, one key thing is what's the average thickness of it when we harvest it from the roof of the mouth, and it will be between 0.8 to 1.25 of thickness. That's the ideal thickness to give you the best color matching. The beauty about this procedure is that anytime we use our own tissue, it tends to creep up, which means it will cover the roots by itself. That process can take up to a year. And sometimes it'll creep up to a full millimeter. So if let's say you did the procedure and you have a 1 millimeter that's not still exposed of the roots, I usually tell my patients just to wait for a year, and it's amazing what you can see later on how much coverage can be achieved. So again, anywhere between 1.8 to 1.2 with an average of 1 millimeter over the next year, it's really predictable with a creeping attachment. So it's something that's a natural phenomenon that we only see with our own tissue. So I'll give you an idea. Again, orthodontic case, really common. Again, what you see is a frenum pole. So that's a small kind of piece of tissue that's between the two front teeth at the bottom. That's called the frenum. Very thin tissue. You can almost see the roots. So the roots are actually exposed. They are showing, but very thin tissue. You can almost see like the roots underneath it, behind the gum, in other words, and especially for those two front ones. So again, that's what your gum graft looks like. It's going to be a slab, a piece of skin from the roof of the mouth. So that's immediately post-op from the procedure. We always use dissolvable sutures. They work really, really well for those cases. Again, this is only 2 weeks later. You can see that beautiful thick band of tissue that's been developing. Another occlusal shot that we see, and I love these ones because you can really appreciate how much thickness we are able to achieve. So that's what immediate post-op looks like. Amazingly, patients never complain about soreness on the recipient side. Maybe 2 days maximum. It's usually the roof of the mouth that tends to be a little bit more uncomfortable for most of our patients. Again, this is it at 2 weeks from the occlusal shot, so you can definitely see a major improvement in 2 weeks already in just the thickness and the quality of the tissue. There's no more that frenum pull, which you see that small muscle that's kind of really tense and tight that's pulling against the gum. Again, another great case. Again, history of ortho, but what's amazing is about, if you look at this case, those two laterals are pushed so far out compared to the two ones in the middle. And this is very common. When patients get braces, they don't follow up with their retainers. Our teeth shift over the years, and the teeth are in let's say, the path of the least resistance. They tend to be shifted more outside, and that's what happened to this patient here. So again, a lot of roots are being exposed, very thin tissue, shallow vestibule. You can almost see where the vestibule is pulling the gum away at this point in time. So these cases, it's pretty much very straightforward. What are we doing? We're doing slapping a new piece of gum down there just to improve the quality of the tissue for the patient. So we take a piece of gum for the roof of the mouth. So there's two sides of it. The outer side is called the epithelial side, and the inner side is the connective tissue side. Normally, the epithelial side will slough off after about a week, just the normal process, just like any skin. It sheds off, a new layer of gum forms underneath it. So again, this is what it looks like immediately post-operatively. Not the prettiest thing, looks like Frankenstein in someone's mouth, but it's normal. It's really natural. This is another kind of side picture of it that we took as well. These sutures are 6.0 microsurgical sutures. They're really small. Sometimes we even use 7.0, which if you've never seen it, you have to wear high magnification surgical loops just to see it because they're really tiny. So again, this is your pre-op, and this is just 2 months later. So again, major improvement in the quality of the tissue. And we were able to achieve a lot of coverage for this patient. It's not 100%, but it is significant. And the reason that we didn't get 100%, well, number one, the tooth is not in the normal position. It's actually pushed so far outside. So there's not a lot of blood supply to cover everything. And also, some of them have been super erupted from the adjacent side. So these are all factors that can, impact on the final outcome. But we were able to achieve really good quality tissue. Now, this is a great case. This is I think it's a 12-year-old patient of mine who is getting Invisalign therapy, and her orthodontist referred to me. He's like, hey, listen, she needs braces, but she's really young, and genetically she has very thin tissue. And if we look at the canines, you can see how much minimal gum she has. You can almost see the waviness of the roots that are protruding on the lower front teeth. So for those ones, are you addressing just the one tooth, or are you addressing pretty much the entire 6 front teeth? So even though she was referred for the 2 ones in the middle, when I talked to the patient, like, listen, you're young, you're 12 years old, after speaking with their parents, it's like, it's best to just address the entire 6 front teeth. So we pretty much took 2 pieces of gum from both sides of her mouth. Again, 12-year-olds, they heal beautiful. So they have very minimal discomfort or pain, but it's incredible what you can do within 2 weeks and 4 weeks time. So again, this is it at exactly 3 weeks later to be specific, but you can see how much gum this patient has now at 3 weeks post-op. Beautiful thick tissue. And I'll show you the 3 months when she's literally has her buttons for her Invisalign therapy. So now it's 3 months later, 12 weeks. But again, you can see from before and after how much thick tissue that she has, and that's not going to go anywhere. She's never going to have a recession for the rest of her life, pretty much. Can it happen? Yes. How likely? Very unlikely. But again, you never know what things happen in the future. But overall, that's your thick, beautiful tissue that's going to stay there. And the orthodontist is super happy. And more importantly, the patient as well, even though she's 12, but she can definitely have a long-term effect and result. And she's going to start her orthodontic therapy in the near future. Another thing we do a lot is dental implants, part of our specialty, especially for our patients that have absolutely no teeth at all. They get implants. Later on, sometimes they will develop loss of tissue around their dental implants. The key thing for implant success is always the more tissue, the better, especially soft tissue, to make sure that it can withstand good brushing and cleaning habits. So if you see on this case, if you've heard of all-in-4 or full arch, full mouth rehabilitation, this is a patient where advanced gum disease, we had to take out their teeth, place 4 implants the same day, and the patient walked out with a full set of teeth on the lower jaw the same day. So these are one of those, full mouth transformations that we get to do for our patients, luckily. And when we fast forward a few months later into the healing, there's pretty much no gum on at least 3 out of our 4 implants. So before we proceed to the final process, we do want to improve the quality of the tissue for our patients. So we did a full mouth gum graft on those 4 implants, from both sides of her roof of the mouth. And again, a lot of sutures you can see. But again, 2 months later, you have now beautiful tissue supporting those implants that's going to just stay there for a very, very long time. And that's our goal. We want stability. We want something that the patient can maintain hopefully for the rest of their lives. That's our ultimate goal. Again, another case for a full arch. So you can see this patient had 5 implants. That's where her gum is. And she's about in her mid-60s, I would say. So again, that's the new gum that we attached, that we harvested from the mouth. And that's it exactly at 2 months later, to be specific. Now she has beautiful thick tissue and she can proceed to the final prosthesis. This is very common with the lower jaw. We tend to see this versus the upper jaw when patients develop gum recession around those cases. So we always explain to the patient later on, like, hey, listen, there's a slight chance you might need a future gum graft on the lower jaw just because the way the gums are, they're really thin. So we always explain that to them so they can be very well prepared. All right. Now, in cases where patients do have natural teeth, but they have other teeth that's been missing for a while, and what happens to us is that, slowly over time, our bone tends to shrink. And what we do is, in order to make it rehabilitable again, we will do a bone graft procedure, we'll add dental implants. Once that all that's been done, sometimes it leaves you with very minimal tissue to go to the final prosthesis. When it gets to that, that's where sometimes, it needs the help of a gum graft for long-term stability as well. So what we do in this case, this patient's had bone grafting surgeries in order to increase the width, but literally have absolutely no gum from all the number of procedures that we've done from them, because it does reduce it over time. So we add a nice thick layer of tissue, and then this is your 2-month follow-up, from pretty much 2 millimeters of tissue. Now you have at least about 12 millimeters of gum. Your implants are placed in the patient's mouth, and this is what it looks like 2 months later. So you went from pretty much no tissue at all to almost anywhere between 10 to 15 millimeters of new additional gum that the patient can have for long-term stability of their final prosthesis. So it's not around just natural teeth. It's not only around dental implants, but it's also around pre-implant therapy or even post-implant therapy. So these are all things that we can really help achieve our patients to overcome for the long-term stability. Now, one thing I remember I discussed is like there are differences between using our own tissue from the roof of the mouth and donor skin. They each have their pros and cons. When we always try to decide, which one are we using? Upper jaw? Is it lower jaw? We talked about patients' preferences. Sometimes they will tell us like, I don't want to go to the roof of my mouth. I've had it one time when I was a kid and it hurts like crazy. And truth to be told, it really does. And sometimes we have to use donor skin. Donor skin is a great option. It does have its limitations when we use it, which means I've seen some of my patients come back with recession again 6 months or a year or 3 years later. So it is common because the quality of the tissue is different. It's not our own tissue from the roof of the mouth. It's different genetics. When we use donor skin, it acts like a matrix, in other words, which means it allows our own gum cells to grow into it, and it just kind of hopefully stays there. So our own tissue, it's the gold standard any day of the week. Color matching is ideal. It does increase your tissue thickness. Disadvantages, it requires a second surgical site, naturally needs blood supply from the recipient side, and that's true for both techniques. Indications when you need for root coverage. The dermal tissue, which is donor skin, again, advantages, there's no donor surgical site. So the nice thing is that it comes in a sterilized package, and there's a lot of it. So if you run out of the roof of the mouth, you will never run out of donor skin. Disadvantage, it's more technique sensitive, meaning that it does have a slightly higher risk of infection. Our own tissue, if you leave it exposed, it's fine. It can take a beating because it's genetically much stronger. Donor skin, it's nothing like that. It's a dead piece of skin that you're hoping for it to revascularize again. So we always keep that in mind. It can give you variable aesthetic results. I'm going to say that's debatable because I've had some, color matching that's literally identical to the patient's own natural tissue. So I'm going to put that as a question mark. Indications, again, pretty much same if you have this need for root coverage, but if you have long span, which means if you're doing an entire upper jaw or entire lower jaw, you do have limitations with using or harvesting from our own tissue from the roof of the mouth. So it can become like, okay, this is just too much grafting. I need to maybe use donor skin for this case. Another technique, which is really cool that we do tend to mix using our own tissue or donor skin, is called the pouch technique or the envelope technique. This is one of the things that I do a lot for most of my procedures, and I'll have a chance to show you what it looks like as well. So developed in 1985, it's a really cool approach. We make a small tiny pouch in the gum and we just stick in the graft. And the results of it are truly phenomenal. So again, recession, this patient has a bridge. The tooth next to that canine is actually a pontic, so which means it's a fake tooth. There's nothing underneath it. That tooth has been removed for a while. So again, this is what a pouch, we make a small kind of envelope and we pouch it in, and then we stick in our gum graft from the top. 8 weeks later, you can see, a little bit of the root is still exposed, about 1 millimeter of it. But amazingly, 9 months later, and that thing is beautifully covered and thick tissue. And this is the creeping attachment that I mentioned. Again, how much can we expect? Anywhere between 0.8 to 1.2 with our own autogenous tissue at about 1 year later. So at 9 months, you have beautiful coverage that was just kind of developing over time. So that's the beauty about those cases when we use our own tissue specifically. The coronally advanced flap, this is my bread and butter. I do these procedures maybe 2 or 3 a day in my perio practice. My perio practice is very, I would say, soft tissue driven, and also the basic periodontal procedures, not much on the implant therapy, but more on the soft tissue therapy. Just because our reputation from my boss that he's been the soft tissue guru in our area. So I did learn a lot from him, and again, something that we also developed over the years from taking advanced courses nationally and internationally as well. So the advantage of the coronally advanced flap is ease of access to the recipient site. It has beautiful coronal advancement, which means I can really loosen up the gum and pull it down as much as possible, which is the verticality. And it has the best aesthetic match because simply you're just pulling down the gum. So aesthetically, it's going to look perfect pretty much all the time from an aesthetic point of view. Disadvantages, it can decrease your vestibular depth. Now, that's also debatable because a lot of research and studies do show that our vestibule will reestablish itself years down the road. So that's something I'm not really, I would say, super focused about, because I've seen that change, at least with my own cases, and research does prove it as well. Indications: when you need root coverage, and when thick tissue phenotype, which is the biotype or the quality of the tissue, and ideal amount of carinized tissue is needed. So again, I like this case because this is a very challenging case. It's a lower jaw. Normally, I love to use the good old pharyngeal graft, but for this case, I mean, this patient, she's in her, I would say, early 60s, developed gum recession, bone loss. As you can see, some black triangles. This is a standard Miller class 3, in other words, where you have some interproximal bone loss, you do have recession. Can we achieve 100% root coverage? No, not really. It's not predictable in any way, shape, or form. But what's amazing is her home care is impeccable, but those teeth are really loose. Now, she does have some occlusal trauma, which means she does bite hard, and you can see the signs of the wear facets on her incisal edges. You can see it goes up and down. So in this case, we did several things for her. We adjusted the bite. We splinted her front teeth as well, just to make sure that they're not moving at all. And then we decided to go with using the autogenous, her own tissue, and the coronally advanced flap. So again, this is what it looks like. We lay a flap, we clean the roots really, really well, and you can see the level of the bone is on the outside of those teeth. You can see the bone starts. That's what it looks like, just to give you an idea, not to scare you. Again, this is the patient's own tissue, autogenous. These are the 7-0 sutures. They are super small. They're super micro, so you definitely need a lot of loops to see them when you're suturing them. And then simply what we do is we just pull up the gum and we cover those roots really nicely, as high as we can, because we know the gum is going to settle down wherever the bone is. So 4 weeks later, this is what it looks like. And I'm looking, it's like, damn, that looks really good. We have a lot of root coverage. The tissue is unbelievably thick. And I'm very, very pleased. 4 months later, this is what it looks like at this point. Nice thick tissue, pretty much almost 100% coverage on most of the roots, except one of the centrals. Again, for a case like this, with this much advanced bone loss, root coverage is not predictable at all, but we were able to achieve some really good, nice outcome for the patient. From an occlusal shot or incisal shot, again, so you can see our small sutures. These are 7-0 PGA sutures, really tiny, really petite. And this is what it looks like when we close it up, nice and tight, close up. Again, 4 weeks again from that occlusal shot. And 4 months later, this is after I splinted the patient's 6 front teeth. So again, are they stable? Absolutely. Are they thick? Yes. Are they healthy? Yes. And is the patient happy? Definitely yes. And that's the goal. Is like the patient doesn't want her teeth removed, even though they were loose, but we were able to fixate them. We were able to stabilize them. And she was seen by a periodontist before me that told her, we need to take all those 4 teeth out and place 2 implants. And, sometimes, you see different specialists, they will give you different opinions and different options, but whatever we can do to give the patient a long-term satisfaction, this is one of it. So, she's happy, I'm happy, and, the key thing is, long-term success. Another great case, a patient who has a history of braces, again, orthodontic therapy, mid-20s at this point in time. But you can see the roots of those teeth are just kind of protruding out, And again, like I said, 90% of my cases has a history of orthodontic therapy. So this patient had braces 10 years ago, and like I said, anywhere between 5 to 10 years is really, really, really common. So again, very thin tissue, because you can almost see the roots. When they did the braces, they literally, in order to get everything perfectly aligned, they push the teeth outside of the jawbone. When they do that, this is what happens. You'll see that prominence of the roots, a lot of gum recession, because, well, there's no bone on the outside of those roots to really keep the gum nice and high. So, what does it look like? So as you can see, almost the roots are literally protruding. If you see on this one, that's the gum graft from the roof of the mouth. sutured with clear sutures. These are 6-0 sutures. They're really small and fine. I added another gum graft on that canine that I harvested from the other side. And this is what it looks like closing it up. Yes, it looks like Frankenstein's mouth at the beginning. Now, the question is, this is what it looks like at 6 months later. Beautiful, thick tissue. The roots are 100% covered, and it will just blend in over the next 6 months even better. But you don't see that root prominence anymore. And now what you've done is that you've added a thick layer of a protective material, which is natural. It's all autogenous, the patient's own tissue. That's just going to improve the quality with time. So, patients are happy with those results because now you've achieved them some long-term stability that they can really maintain. So again, that's your before, that's your 6 months later. So a major improvement in the overall health for this patient that we were able to achieve. Again, another case, also history of braces as well. Now this guy is in his 40s, much older, but what's happened over the years that those forefront teeth have been super erupted. And this is a really great case where there you can see small papillas, everything's been super erupted. We know that you're not achieving any coverage on those forefront teeth, but the canines still have a much better chance because the bone level is in the right position for those canines. But what you can see is there's small frenum pulls from the sides behind those canines and very thin tissue. So I think this is maybe one of my longest gum grafts I've taken from the entire roof of the mouth. This is a one-piece graft. I don't think I'll ever do it again because I have no idea how I did it. This is a one-time effect. And this is what it looks like. Literally, I just kind of wanted to do some more photography with it. So I took a lot more pictures just to see how long this one is. It's about 4.5 centimeters long, which is literally the entire length. This is what it looks like closing it up. So very nice and tight closure. This is at 4 weeks. It looks hideous naturally. And this is when we remove the sutures for the patient. But again, great root coverage. And this is it at exactly about 8-9 months later. So beautiful thick tissue. The canines are 100% covered. Those 4 incisors, major improvement in the quality of the tissue. Why did we not get any root coverage? Well, simply because the teeth have been erupted outside of the jawbone. So if those teeth were in the right position, which means if they're pushed down in, those roots will be all covered by beautiful natural gum. So again, this is your, actually they're 6 months later. This is your pre-op and 6 months post-op later. So definitely major improvement in the quality of the tissue, the thickness of it, and long-term stability. Anything more than 6 months that looks as stable as this, then pretty much at that point in time, we're really not concerned that it will progress significantly. Can it progress though? Absolutely yes, but we do educate our patients on how to really brush it and maintain it for long-term. In another case of your coronally advanced flap with some gum grafting, I like this case I want to show you because this is iatrogenic dentistry. This patient had recession and they decided to put fillings on those roots. And you can see those white discolored fillings at the bottom of those roots, like where they used to have gums. This is something for us, like it's our nightmare because we have to remove them all and we have to clean those roots really well. And a lot of times we see a lot of decay developing underneath those cavities. So make sure if you go to see your dentist and you have gum recession, don't let them do this to you guys. Make sure that you send you to see a periodontist. They can address it more, either using their own tissue or donor skin. So again, this is the patient's own tissue from the roof of the mouth. And then basically we close it up, cover it really nicely with some sutures. And this is at 4 months later. So you get 100% coverage from before and after, and just long-term stability, and just it thickens and gets better and better with time. And that's the main goal and purpose. Now, this is another patient who she's in her, I would say maybe about late 30s, early 40s. She's had a canine that was impacted deep down inside, and they pulled it down. But when they pulled it down, they didn't pull it down in the right position, which means that canine, if you can see, it's rotated. It's actually outside of the jawbone. So, and it also has a lot of bone loss. Now, very sensitive for this young patient, and literally no gum at all. And she was very careful as far as brushing it because it was just too painful for her to anytime the toothbrush touches the gum. So remember I mentioned to you, I rarely do a regional graft on the top teeth because it's very unaesthetically pleasing. So as you can see here, we did it for her because she had no gum at all to start with. And she had a lot of bone loss as well. So are we going to expect complete coverage? Absolutely not. So when you have those cases, we do sit down and discuss it with them. Like, listen, I'm going to, first of all, establish some new gum for you. Then I'm going to come back and I'm going to pull it down so I can see how much coverage I can get. So that's exactly what we did for her. We first of all established some new gum, and you can see that new layer of tissue. And then about almost 2-3 months later, we added donor skin because she didn't want to go back to the roof of the mouth because it was, definitely uncomfortable and more painful. So we closed it up, and this is what it looked like exactly 2 months later. Now, I saw her for the third time at this point because she had bone loss, and then we needed to address the bone loss. So we did the bone graft procedure between the canine and the tooth in front of it, and we covered everything, and we pulled down the gum again one more time. So right now she's almost at 3 months after the bone graft surgery. I didn't post the case yet, but the root is 100% covered compared to what we started. So we achieved, we grew the bone predictably again one more time because we had gum to protect it. And we also regrew the gum again. So all these things we did for this one tooth because the patient was adamant on saving it. And I was there to help her achieve that long-term result. So versus having it removed and placing, let's say, dental implant. So whatever we can do to improve the quality of the natural tooth, it's always the best option for our patients. Now, one of the most hardest areas to treat is the inside of the lower teeth. Why? Simply because there is something called the tongue, and the tongue is one of the strongest muscles inside our mouth. This happens really common if you have a tongue ring. It's really, really common. We don't see it today anymore. It's a lot less than in the past, but these cases are maybe 10, 15 years old, who their patients had tongue rings, now they remove them. But this one can really result from a tongue ring situation, where there's literally very minimal tissue, and not only it affects the gum itself, but it also affects the underlying bone. So predictability is not always great in achieving covering those roots. It's just more of improving the thickness of it more than anything else. So what we do is we add a gum graft on the inside, and then we close it up. So it looks really nice, like, yay, we got a great closure. But 2 months later, 3 months later, this is 3 months, you can see now, the gums have receded a little bit, but now you have a thick band of tissue that's just going to stay there for a very long time. So again, why did we not achieve great results on this one? Well, number one, again, very minimal bone. And number two is the position of those two centrals are too far forward. So there's, that from a blood supply standpoint, you don't have a lot of blood supply on those roots. So it does minimize you getting long-term results as well. This is a credit of my co-resident, William Trahan, who was kind enough to share his case with me as well. So again, this is another case, history of braces, but you can appreciate how much of those roots have been sticking outside of the jawbone. And he did a beautiful, again, patient's own tissue, gum graft, thick. He closed it up. And again, 3 weeks later, 100% root coverage. And this is 6 months later with, again, incredible, I would say 99.9% root coverage. Now, the success for this case is because the teeth were perfectly aligned. If you can see, there's a lingual retainer, and therefore he was able to really get predictable coverage on those cases. So again, this is what we'd love to achieve every single time. Is it predictable on the inside? Not really, no, but again, we always tend to do our best. So major improvement from before and after, so that way this case does not develop and progress in the long run, and patients don't experience more bone loss and eventually tooth loss. So that gives you an idea of what this one looks like. Another thing is dental implants. Dental implants, they're becoming more and more popular in today's day and age. Dental implants they behave very differently than a natural tooth, meaning that sometimes you'll see recession develop around our dental implants. Sometimes the bone thins out and you'll see something like this, which looks gray. That gray is literally the implant underneath the gum that can start showing. So if you have a congenitally missing lateral incisors and you're getting dental implants, keep in mind that sometimes over the next few years, something this can develop to you over time. So we do advocate now, compared to the past, is we always add a gum graft anytime we do a front tooth implant, so that way it helps with the masking effect of it, so we don't see this over time. So these cases are very challenging when you do around dental implants, because again, it's not a natural tooth. It's a piece of metal in the jawbone. So how does the gum behave around it, when lack of blood supply? So again, this is a great occlusal shot. You can see there's a huge dip. You can see the changing color. And surprisingly for this young patient, her jawbone was spitting out some bone particles that she had grafted many, many years ago. So again, this was developing 4 years later after she got her dental implant. So again, we have to be very careful with our incisions, being more on the minimally invasive side, from incision design to suturing techniques and all that stuff. So, we open it up, we clean it very thoroughly. We add a small, tiny gum graft, and then pretty much we close it up. It looks like a spider's web when it's all nice and closed. Again, your occlusal shot for that one. Again, we use very 060 microsurgical sutures. This is at exactly 2 or 3 weeks post-op. So it's nice, it's very thick, and this will just kind of blend in and mature with time. Again, this is what it looks like at exactly 2 months later, almost, I believe, or 2 or 3 months later. Yeah, 2 months later to be specific. So beautiful thick tissue, no more that facial dip that she had on the facial aspect of that implant. Unfortunately, she went to law school, so I was never able to follow up long-term with her, but I was able to see her at least on the 2 months follow-up before she went to law school. But again, these are the situations where, gum grafting does have its really key and importance when we do those interior aesthetic implant cases, and kind of the long-term effects of, the consequences of not performing it when you're getting your dental implants in those interior sites. So again, that's your pre-op, that's your 2 months post-op, and with time, it's just going to mature better, it's going to look better, and eventually it's going to blend in very, very nicely. And again, another case where an implant was placed 5 years ago, and the guy just forgot to put a tooth on it. So again, what happens is that the site over time tends to shrink, and you start losing that dimension of it, the volume of it. So now he comes in 5 years later, it's like, hey, my implant is buried in there, but I need a tooth. So, when you look at this, it's like, okay, well, we can help you. So we'll add a gum graft to it. And that's what we did. We added a simple gum graft. We made a temporary tooth immediately at the surgery time with the gum graft. And this is it healing exactly about 2 months later. So again, nice, really mature healing. And this is at 4 months. So that's the before and after of how much improvement in the aesthetics and the quality of the tissue that you can develop just by adding a simple gum graft and a temporary tooth on that patient. So again, now he's ready to get his final crown in for him. So for me, I see there's a really great, soft tissue long-term success of before and after cases. Again, another implant case for this young, beautiful young lady who's in her 20s has had trauma, about 5 bone graft surgeries at this point in time. Implant was placed. Her teeth have been super erupted between the central and the lateral incisor. A lot of the roots are showing, and she has some severe bone loss. So it's like, you can regrow the bone to a certain level, but it does have its limitations as well. So at this point in time, after 5 surgeries and a lot of grafting, and implant has been placed for surgery number 6, now the oral surgeon sends this to me. He's like, hey, can you do something about the gums? And I'm looking at it, it's like, holy cow, what am I going to do at this point in time? This is like way too advanced, and, kind of a little bit late on doing the gum graft surgery. So this is your occlusal shot. Great dimension-wise, on my, buccolingual dimension, but height is your big challenge here. So again, this is a case where we said, let's do a kind of like a tabletop technique where we add 1 layer on the outside and 1 layer on the top. So this is an outside layer. Again, these are 7/0 sutures, really small, really micro. And then another gum layer on top, like a tabletop approach. And then we stabilize it. And then we really try to advance that gum as much as possible to see if we can get some better coverage of it. And this is it closed. Again, there's a lot of things I can critique myself about this case. Number one, the use of the suture materials. But again, you do have limitations from the scarring tissue. I mean, when we reflected this one, there was a significant amount of bone graft particles that was embedded deep into the tissue, and that really limits the amount of advancement of the gum. But this is what we were able to achieve. So this is at 4 weeks later. Again, major improvement compared to the past, thicker tissue for sure, and improved in the gum height, if anything at all, which I was really surprised to achieve, especially on the outside facial. 3 months later, so now it's a lot more mature, again, a lot more stable. At this point in time, this is where your prosthodontists can come in and they can start really finicking and touching up those two teeth at the front, and then adding a temporary tooth to really help reshape and remold the tissue. So I sent it back to them. I haven't seen the patient yet for the final post-op, but I'm hoping it does look much better significantly prosthetically wise. And then hopefully more of the roots are going to be covered. I did tell the patient, listen, we can do this for a second gum graft. But it's like, I promised her that we might not be achieve, more better results. So she's like, she was happy at this point in time. And she just wanted her to, because it's been almost a 1.5 year process for her until I got to see her at that point in time. So other techniques that we do tend to do is called the tunneling technique. This is one of the most, I would say, minimally invasive approaches that we tend to do. We don't reflect any gums. Everything is done literally microsurgically. It's really fun to do those techniques. They do have its limitations, advantages, disadvantages, and also I tend to nit and pick which sites of the mouth that I like to do those ones. So advantages: great blood supply for the graft nutrition. It's much quicker healing. Aesthetic outcome is way more superior than any other technique because you're not reflecting anything. Everything's done microsurgically and through the gum itself. Disadvantages: there's limited flap opening. That's very true. Indications: when you need root coverage and you have a nice thick tissue to play around with. So this is a really nice case. This was a pre-orthodontic therapy. This guy had some severe gum recession from aggressive brushing habits, and his orthodontist sent him to us like, hey, can you do something about those gums of his before we start his braces? And he's like, all right, cool. So I gave him 2 options. Hey, listen, you can use your own tissue or you can use donor skin. Your own tissue, I told him, is the gold standard. It hurts more, but it's always better for long term. So he decided to go with his own tissue. So again, these are 2 pieces of gum from the mouth, and we pretty much tunneled everything for this patient. Again, this is what looks like closed up. So there's no incisions. Everything's done literally tunneled through the sulcus, through the gum itself, and it's inserted and then sutured back up. So this is at 3 months. At this point in time, we got root coverage, the canines are protected, the centrals are protected, and now he gets to go back to start his orthodontic therapy. And we're going to monitor everything to see if he needs any additional touch-ups as the orthodontic therapy progresses. So again, that's your that's your pre-op, that's your 3 months post-op. So major improvement in the quality of the tissue, the thickness, and now he can start his orthodontic therapy. Again, another case of a tunneling approach. Again, this is a post-orthodontic therapy, tunneled as well. And you can appreciate how the roots are just bulging out of the bone. It's not supposed to be like that. But again, orthodontic therapy has changed a lot over the years, and we're seeing this just more and more as a result of it. So again, that's your gum graft that we harvest from the roof of the mouth. And again, it's tunneled in, and this is your 2 months post-op. So beautiful results and healing, so before and after, thicker tissue, no more of that bulging roots that you can see, but more of a thicker, improving quality type, and 100% coverage of all our roots that are showing at this case, even though this is a Miller Class 3 recession. So again, should I expect any potential gum recession for this case? Possibly, because there's some bone loss between the roots. So I do explain that to the patients that this can happen later on in time. Again, this is posterior teeth, again, another tunneling technique. So this is what it looks like, again, when the graft goes inside the mouth. There's no incisions, there's no cuts, everything is just tunneled in through that tissue for the patient. Again, so this is it again, 2-3 months later, and just a kind of a before and after, what it looks like as well. So again, major improvement in the root coverage and no more sensitivity for the patient. Again, another beautiful, I think, case that we were able to see again. This gentleman is in his about 50s, severe bone loss, a lot of pink triangles, and we decided to go with, again, donor skin, knowing for a fact that we want to achieve 100% coverage. But again, that's your tunnel. This is donor skin, one piece from one side to the other, from your premolar to premolar. He does have a history of orthodontic therapy as well. He has his premolars missing from they took them out before his braces. And this is what it looks like immediately post-op suture. So again, it looks like Frankenstein, I agree, but they're only like 4 knots in total. So very minimally invasive, not a lot of sutures involved in this. Again, this is your 3-month post-op, or actually 2 months post-op, if I'm not mistaken, 2 or 3 months, 3 months post-op. Again, so your before and after, as far as results-wise and how much coverage we were able to achieve for our patients. So again, major improvement that we can do for them. And last case for this, before we kind of wrap it up and close it for you guys, again, another history of severe gum recession on the centrals, laterals, both top and lower jaw, actually. So this is a case for the top, just so you guys see the pictures of before and after. Again, tunneling technique, no incisions, no sutures. I'm sorry, no cuts, just simple sutures. This is a one suture that goes back and forth all the way. Again, this is your 1 year post-op. So beautiful thick tissue. Again, at this point in time, we had finished the lower jaw as well. So that's almost about 9 months post-op for the lower left side. And then we finished the lower right side this year as well. So again, beautiful results from before and after. So this is what you started with, upper and lower. And this is what we ended up with for both, at least for the upper side. So again, major improvement on your laterals, your canines, your premolars, and your molars as well, and especially the 2 central ones. So aesthetically, this is more of an aesthetic dilemma that the patient was dealing with, and also sensitivity. So what are the final, this is a final slide. What are the surgical limitations, and techniques? It's not always predictable, even in the best circumstances. And we do explain to that very well to all our patients, like, hey, listen, we're going to do our best. Sometimes it works beautiful. Sometimes it does have its limitations. Sometimes we might require another, touch-up or revision procedure, we call it. Blood supply is the key for all our gum grafts. It needs a source of blood supply to revascularize that piece of tissue that we just added there. It also depends on the baseline of amount of keratinized tissue. The more we have, the better, because simply there's more blood supply. And the amount of recession, and the amount of graft required. The deeper the recession is, naturally it's going to be a little bit more challenging to achieve those predictable outcomes. And systemic factors, smoking is our #1 enemy, uncontrolled diabetes. If you smoke and you have uncontrolled diabetes, I literally tell them, well, stop smoking and control that before I come and see you, because I know for a fact that every time we approach those cases, we do expect a lot more failures when we have those issues that's been uncontrolled. And the patient factor, which is the overzealous brushers. Their home care is impeccable. They just brush their gums away. So we do educate them. And the key thing is toothbrush modification. What can we do to teach you guys to make sure this does not happen again after the procedure? So that's always really, really key. So I think at this point I do end it. Again, thank you all for your time. And if you ever want to see more of my surgical cases, I post everything on my Instagram, and you can feel to follow, and you'll see the different variety of what periodontists do from a surgical technique, whether it's soft tissue, grafting, bone grafting, implant therapy, and so on. So thank you again for your attention, for your time. And if you have any questions, please feel free to ask me as much as you want.
Thank you, Dr. Hasan, for this wonderful presentation and taking the time to explain each process and technique to us. We really appreciate it, and it was really interesting to learn about your experience and your cases. So we actually have a few questions for you, and if that's all right.
Of course.
Okay, sounds good. So the first question is, What techniques do you recommend for individuals with braces to prevent like periodontal disease and like recession?
So it really depends on if they have recession ahead of time, or is there, or if there's no recession at all, and at this point everything's very well maintained. It's all about maintenance. To prevent any future recession with orthodontic therapy, it's all about the progression of your orthodontic treatment. Meaning, if you do have, and that's it only depends on your orthodontist. Your orthodontist needs to pay close attention. If they see anything, they need to refer you out at that point in time versus allowing it to progress. Prevention is key, so it all comes to the diagnosis and how much your orthodontist, the knowledge that they have. If you are in your teens, let's say, and you're getting braces, if you have thin tissue, that's something they should recognize, send you out, get it addressed maybe early on before you start your orthodontic therapy. If you're in your 20s or 30s and you're going for your round two, let's say you're getting Invisalign now, which most of our patients now, they do have at least, they've had braces, have had orthodontic therapy twice. The first time was braces, the second time was Invisalign. At that point, when you're older, you have to have at least be seen once by a periodontist, because the way the disease progresses, if it develops, it tends to be more aggressive at an older age. So it's always good to get that periodontal clearance first to make sure that your gums are healthy, your bone is healthy, everything's stable, so that way nothing progresses or develops, at least over time. If you do develop it during orthodontic therapy, it's not a big deal. We treat it. Sometimes we'll stop the orthodontic therapy for like a period of a month or so, or 6 weeks, just for allow the soft tissue to heal better, and then you can continue again with your orthodontic therapy. Now that's true for gum grafting. If you have bone loss, it's very different. Bone loss, it requires a longer time of healing, anywhere between 6 months to 9 months, up to a year, for that bone to mature well enough before we can start continuing with your orthodontic therapy. So it depends on the nature of the disease that you have. Is it gum grafting? Very minimally diseased, but versus bone grafting, that's much more advanced. So you do have to know what you have to start with.
Thank you so much, Dr. Hasan, for your response. Another question is, how do you develop your treatment plan when working with patients? What are the factors taken in deciding what to do next?
From a soft tissue perspective, if that is go from a gum grafting perspective, or just generally speaking?
Generally speaking.
Well, I'm a periodontist, so I get to see patients where they're in their worst situation from periodontal health. Patients never come to me first. They are always referred to me from my referring doctors. Meaning that there's a referral slip, they'll say, hey, please evaluate site number so and so and so for either advanced periodontal disease. My job as a periodontist, I'll do a full clinical examination, we'll look at x-rays, do our charting, periodontal charting. Then we can, based on that, we can see what's the diagnosis, what's the prognosis, the etiology, and the best recommended treatment plan case by case. So we do take a lot of factors into consideration from that standpoint, and whether it's just generalized severe periodontal disease, whether it's gum therapy, whether it's implant therapy, we will always discuss the pros, the cons of every treatment, so that way the patient is very well informed. And again, our job as healthcare providers, that we need to let them know what they're dealing with. It's not just about opening up your mouth, let me do this and this and this, and they look like, what the hell are you talking about? But I do really break it down and dumb it down to them as much as possible to make sure that everything I explain, sometimes if I have to draw on a piece of paper, I will draw it. And that way I can just make sure that they take ownership. That's the key. Because if the patients don't take ownership, they will never proceed with treatment. And this disease didn't happen over time. It developed, so it didn't happen immediately. It did develop over time. So they need to own that fact that this was because maybe your neglect. And I'm honest with my patients. I'm very straightforward. Like, hey, listen, you did this to yourself. Now let's focus on the future. What can we do to make sure this doesn't progress? And how can I help you? Not just by myself, but I need your help too, to make sure that we can control and we can preserve your teeth, or we can preserve your gum. Or if you're going an implant, the implant's going to stay there hopefully for the next 10, 20, 30 years if possible in your mouth. So I do have them, be part of that ownership, and that way they can stay as long as possible.
Thank you, Dr. Hasan. So the next question is, are there any techniques that you use when dealing with like uncooperative patients or patients with a mental illness?
So we do sedations for our patients. A lot of our patients, especially if they have, I would say, autistic or other, mental issues. I would say mental health problems. We do a lot of, sedations for them, whether it's oral sedation, IV sedation, to get them as comfortable as possible, and that way we can perform as much procedures for them in that one setting. Sometimes if their patients too advanced from a healthcare standpoint, we bring in an anesthesiologist, and they will put them to sleep while we get to address their dental needs. It does sometimes even work with sometimes have more than one specialist in that room between a periodontist or a prosthodontist together combined, or your general dentist or your pediatric dentist, for example. So we do work multidisciplinary, a collaborative teamwork for those patients. There's a lot of heads up calling, scheduling, coordination to make sure we can really provide the best quality service for our patients who those have a lot of mental needs.
Thank you, Dr. Hassan, for your response. Another question is, if an individual has teeth sensitivity, is that because of gum recession or exposed root? And what would you recommend to patients with sensitivity besides gum grafting?
So if you have if you have sensitivity, you can see your roots. If you just pull down your lip or pull up your lip, the roots are not supposed to be shown. You can only see supposed to see the enamel only, okay, the crown part. If you see anything else beyond that, that means you have root exposure. So yes, you can do a gum graft, and that will fix it. More of a better long-term solution. Preferably your own tissue. Yes, it's more uncomfortable, but it does give you the best long-term results for 20 years, hopefully longer than that. Other thing is you can use just your prescription toothpaste like Prevident 5000 or Sensodyne. Those are your other options. The key thing is what's the extent of the recession? If it's more advanced, more than 3 or 4 millimeters, then we know from studies that it does have a tendency to progress, very quickly. So if you're young, get it done now, because the younger you are, the quicker your healing is at the end of the day. You don't want to do it when you're 50 or 60. And I tell this to my patients: if you have 3 millimeters of gum recession and your gums look like this right now, what do you think it's going to look like 10 years from now or 20 years from now? Do you think it's going to look exactly the same, or do you think it's going to or do you think it's going to get worse over time? And truth to be told, it will worsen over time. It might progress slowly, but it's going to worsen. And when it does get worse, it's going to be much more difficult for us to treat. So I do always recommend, when there are specific criteria that we look at and it reaches that criteria, we always recommend to approach it as early as possible.
Kind of a follow-up question to that. Is there ever an instance where when you have gum recession, for your gum to recover on its own or grow back after experiencing that loss?
Nope. Once it happens, it happens. It will nothing can make it go back again. Unfortunately, that's not how our body works. It's not like you break a bone and your bone is going to heal. Gum grafting is the gum sits on that bone. So if you lose the bone around our teeth, it's lost. Unless we tend to do some other bone grafting procedures to help it regrow again. But normally gums, once we lose it, we have to help it regrow it back by doing a gum graft. We have a saying in our periodontal world, is that bone sets the tone of the tissue, and tissue is the issue. So if you have the bone, the gum is going to sit on it. If you don't have the bone, basically the gum is just going to go away. So tissue is always the issue, but bone sets that tone first.
Thank you, Doctor.
To kind of follow up on this question, is there a limitation to the amount of times you're able to do gum grafting?
Good question. That's a great question, actually. So from the roof of the mouth, we usually, if we're going to the same site to do the harvest, we will actually wait at least minimum 3 to 4 months, allow that gum to regenerate again, because our gums will regenerate completely from the roof of the mouth when we harvest. Donor skin, basically, it's abundant, it's available. So, you can use it as your other option. It's a great viable option, has great success rates. It's just more technique sensitive. And the long-term data shows that they're really comparable with the results. Personally, myself, I do have my own restrictions with using donor skin. I don't use it for the lower jaw unless it's an entire lower jaw arch of gum grafting. Why? Because I've seen some of my own cases recede over time. So it can happen. And sometimes the patients tend to brush it aggressively again, and they can cause recession again. Though our own tissue is a lot more superior, it does tend to thicken, improve over time, at least from my experience that I've seen, and so I do prefer our own tissue for the roof of the mouth. I'll do it in phases, like right side, left side. Sometimes I'll break it down to 3 phases if it's the entire lower jaw, but most of the time I'll do it in 2 phases, right side, left side, with using their own tissue, and I'll go through both sides of the roof of the mouth, and if that's the case that we need. And I showed you a lot of cases where it was a lower jaw, and I literally went to the both sides for the roof of the mouth so I can reestablish new gum for them. So it's very doable. It's all about technique and learning it over the years.
Thank you, Dr. Hasan. Another question is, are there any negative side effects for patients who bleach or whiten their teeth, even though they have sensitivity? And does this affect your gum health?
Bleaching, no, unless like in today's day and age, I think with bleaching, the technology has advanced significantly. The home bleaching is, of course, a lot more superior. It does give you much better results than the Zoom in-office bleaching, at least from what I've seen. The Zoom in-office bleaching, the concentration is much higher, so it can lead to more sensitivity, especially if you have exposed roots. Will it make it worse? No. As far as recession-wise, bleaching does not make it worse unless you forget to protect the gum while you're bleaching. Then you can literally burn the gums away. But normally now there's a lot of protectors like gingival, applications that you can apply to it that your general dentist can do, and that helps significantly with reducing, trauma to the soft tissue from the nature of the material that's used for bleaching. So long-term wise, besides sensitivity, that's the only thing that a lot of patients do complain about. Again, some patients have no sensitivity at all. Some patients, I've had one patient literally end up with root canals on pretty much all their teeth because they did bleaching once because their teeth were just oversensitive. They couldn't tolerate it anymore. So, I always recommend try the home bleaching first because they do come sometimes in 2 different concentrations. There's one that's less concentrated than the other, and it does cause a lot less sensitivity. However, the effects of it is much slower. So try with that first, because you can easily take it off. If it's too sensitive, you stop wearing it and get back on it again.
So following up with that question, like the whitening strips, you know how when you just stick it on the tooth, so you're not really protecting the gums. Would that
Yes.
be a bad?
No, that's fine. I mean, that's very minimal as far as that. You actually barely have any. I've tried those. I've never had any sensitivity myself. But no, it doesn't affect the gums at all. Those ones don't affect the gums at all.
Okay, thank you.
Do you have any advice or any recommendations for students to strengthen their applications for dental school and for residency?
What was the question again? Do you have any advice for what exactly?
Oh, sorry. So do you have any advice or any recommendations for students to strengthen their application for dental school or for residency?
Good question. For dental schools, I think it's really key. If you are a pre-dental, I think shadowing at least, or at one point I'm assisting in a dental office. It does help significantly because number one, it shows that you have some form of dental experience. Letters of recommendation from those offices are really always encouraged. Research in the dental field improves significantly to really improve your application for dental school. Residency is slightly different because you're already in dental school, so it's all about which specialty you're into. Some patients, they come in already into dental school. Let's say they've been an assistant for an oral surgeon for X number of years. They've been assistant for a periodontist or for an orthodontist or a prosthodontist. So a lot of them come into dental school, they already set in their mind what they really want, future-wise after dental school and which residency they want to get into. So you'll see them that they'll spend most of their time in one specific specialty, pretty much from day one all the way to the time they graduate. So they've developed a relationship with the residents, with the faculty, and when they're ready to apply to residency, they have the letters of recommendation already pretty much set in stone from by the time they get into clinics. But again, so that's just my only recommendations. That shadow. That's what I did at least. I shadowed a lot of dentists, and I assisted during my summer breaks whenever I could, and that definitely helped strengthen my resume and my letters of recommendation. At least moving forward when applying to dental school.
Thank you, Dr. Hasan, for your response. Another question is, what do you find most difficult in your specialty, and what do you like most about your specialty?
Oh, good question. The most difficult is patient compliance. I think that's the one thing that most periodontists, I would say most dentists, they do struggle with, generally speaking. If patients comply with your instructions, especially from a surgical standpoint, at least, is when we do those procedures, we don't want to do this again. It's already traumatic enough for a lot of the patients to do it once. No one wants to do it again. So the smokers, the uncontrolled diabetics, the patients who just don't get it, those ones are the ones that gives us a hard time because we have to redo this again. And the question is, from us, are we charging them again or not? So then it comes to the, that question of it. Patients have to take ownership. If it's something that, let's say, during the procedure that, let's say, an infection rose up, unexplained. Normally, for myself at least, I do everything at no charge. But if I know the patient's a smoker or they're uncontrolled diabetic, and let's say they told me that they quit smoking or they controlled the diabetes when that's not true, and they lied behind my back, that's the one where I do get very upset with my patients, and I do have them take full responsibility for that outcome. So that's something that we always wish to improve. And again, for us, no one likes failures, no one likes complications, so really do not like. What I love about my specialty is I really hated perio, to be told. I was one of my least favorite subjects in dental school. I got into it because one of my faculty back in dental school, just he decided to make it like a study club after school hours, and we would just, whoever's interested in perio or wants to know it better, come in. So I signed up for it, and that's how I got into perio, and I love everything about it. For me, my passion is about soft tissue grafting. I was lucky to join a practice where we had strong emphasis on soft tissue grafting, and I've just been slowly developing my techniques over the years. It's been 5 years in private practice. By all means, I'm nowhere perfect or anything like that, but I do strive for that. So it's one of my passions, and hopefully someday I'll, be the soft tissue guy in my area, in the Northern Virginia DMV area. So that's my ultimate goal. So it's just all about, the more education you put into it, and the more advanced courses you take nationally, internationally as well. And just, kind of speaking with your colleagues about different approaches, different techniques on how to really improve yourself. And you'll see, the more you do it, the more you get in love with it. So yeah, that's my kick about why I like perio specifically.
If you don't mind answering, but why did you choose Colorado, Denver specifically for dental school and VCU for residency?
Good question. So as you know, I'm a foreign trained dentist. I finished my dental school back in Iraq in 2007. So when I came to the States, you have to study your TOEFL exam for your English and your Part 1, Part 2 MBD boards, which is your National Dental Board examination. Luckily for me, now, when you're a foreign trained dentist and you get into dental school, you're only doing the last 2 years of dental school. Some schools you have to do the last 3 years, so second, third, and fourth, or sometimes you'll do just the third and fourth. Colorado was one of the first schools I applied to. I literally applied on their deadline, which was, I think, March 31st, and deadline was April 1st. So I overnighted everything so it can be arrived by April 1st of that year. And luckily, it was the first school I applied to because their deadline happened to happen the time when I just finished all my exams and my tests, and I got all my paperwork together. And the other schools, their deadlines, their new cycle was starting to open not until September. So this was the last school of that cycle, and I got lucky. I applied to it, and I got an interview. I got a letter like maybe 2-3 weeks later. It's like, hey, you've been accepted for an interview at the University of Colorado in Denver. So I interviewed. We have our bench exam test for us foreign trained dentists, and another and like an interview, and they collect the scores of both. And I got accepted. 2 weeks after that, I got the letter acceptance. So yeah, I mean, I literally got lucky to be, within my first year being in the States, I already had shadow dentists. I had went to a GPR residency to shadow the doctors there just to see what they were doing. I sat with their study clubs, discussions. I got letters of recommendation, studying at the same time, taking my tests, all that stuff within my first year of being in the States. So, I got into Colorado, and the reason I moved to the East Coast at that point in time, because I was looking for other residencies. Number one, I wanted to be more on the East Coast, and VCU. I got into two schools, Maryland and VCU, which were the two schools I literally just applied to for perio, and because I heard great stuff about them. I had friends already at VCU itself, and they spoke very highly of the program. And I already did my externships at Maryland while I was in dental school. And I went to VCU because simply it was tuition free compared to Maryland at that time when I applied. So it was one of the very schools in the country that were tuition free for your residency. And also had the experience of the IV sedation, which I really wanted to, as a practice builder for myself, and I do IV sedations pretty much on a daily basis for my patients. So IV sedation was a big thing, and the fact that it's tuition free. And when you graduate from dental school with a lot of student loans, you want to minimize that as much as possible. So that was one of the reasons, and it just had a great reputation from graduating really great quality residents over the years, and it was like they had a really phenomenal curriculum, which is why we decided to go with VCU. And the proof of it is I still go back and teach because it's a great program and I love giving back to it. So whatever I've learned through residency and years later on, I try to give it back to my residents now when I teach them.
Thank you so much for your response. And our last question this morning is going to be, how do you balance work and life? Or actually, how did you balance work and life during dental school residency and currently?
Oh, I mean, when you're in dental school, it's pretty much you have your friends, and you have your studying buddies that you tend to study with on a daily basis. And I'm going to be honest with you, in dental school, I think I partied every weekend. Not I think I went every weekend drinking in bars and all that stuff, just because it was really stressful with the international student program that we had at Colorado. And the way they did it was they crammed 4 years into two. So we took 30 credit hours in our first semester. So we were literally like, we needed a day to just go out and just like, screw this, I want to drink. And again, I was 25 years old at the time. So, that was for dental school. Residency, it's much different. You're already a doctor at this point. You're already a dentist. So there's it comes with a different level of stress, and that is you have to study a lot, because residency, I did not expect to have that much studying, and between that and research and masters that you have to do for your thesis. But we were still able to have a good time, with your colleagues, with your residents. You grow memories, and again, it's a small number of group. Like we're only 9 residents total from first year to third year total. So we developed a really great relationship, with them over the years. And yeah, there's always balance for life. You go out, you meet people, and socialize. Of course, that's just normal. Private practice after residency, it's very different for me. Like, I have a routine now. I wake up at 4 a.m. every morning. I, work out at 4 a.m. until like 6:30-ish, and, get my shower. I go to work. My work starts either 8 or 9, depending on the office that I'm at, until like 5 or 6. And then sometimes I have other offices to visit after. I have sometimes continuing education. I lecture a lot, locally for our study clubs. I've done lecture nationally as well. So you have to create that balance. For me, I like to start early in my day because that's when I'm most energetic. So that way I get that out of the way, where, just do my workout, get energized for the morning, finish my work. And then if I have other stuff to do, for example, doing PowerPoints, case presentations. I like to make sure that it's always done, either at the evening or on weekends. If I'm giving lectures like this, for example, for you guys. So I like to make sure, I have all my stuff organized. And is there time for social? Absolutely. Yes. There's time for yourself, for your family, that you have to create, and it's a balance. Everything's a balance, it's passion. For me, perio is my passion. I love it a lot. And my friends, colleagues, my family, they'll tell you, he loves perio maybe more than anything else, just because of how much time and effort I put into it. So you do create enough time for it, and you also create enough time for everything else. But yeah, it's all about investing in yourself, and investing in your quality of life as well, and also investing in your work. And eventually, with time, you're able to create that balance. If you're in your 20s, early 20s, at this point, there's a lot to think about. Me, I'm 36 years old at this point in my career, so I've been established myself where I want to be, where I'm aiming to be in the future, and there's always more room for growth. So it's you reach it eventually. You will reach it. It's just about hard work and dedication. It's not impossible. I'm not the smartest guy, honestly. I guess I had a good GPA, not the best GPA in dental school. And I went to residency with some of the smartest kids, honestly, and they're phenomenal periodontists and surgeons. But I'm a hardworking guy, so I like to make sure that I put my effort in anything I go into it, and something that you guys all do anyways on a daily basis. So I'm not any different than any one of you, honestly.
Thank you, Dr. Hasan, for your time in answering all of our questions. And also thank you to everyone who joined us today. Just before we end today's session, the link for the quiz will be posted in our GroupMe. And thank you, Dr. Hasan, again for being here with us. And we hope that you all have a good day.
Thank you so much for your time. And if you have any questions, again, feel free to reach out to me. My Instagram is open to anyone, and I usually text and get back to everyone any day of the week, seriously. So you have my contact at any time. So please feel free.
Thank you so much, Dr. Hasan, for everything. We really appreciate your time and this wonderful presentation.
You're welcome. Good luck with school and applications.
So I went ahead and I just ended the live. Thank you so much again.